Hi, and welcome to today's session of the Natural Birth Summit. Today, we're talking about complications in labour and birth, and we are fortunate to have Lisa Marie Oxenham with us. Hi, Lisa.
Hello, Adam.
Thanks for coming and joining us. Lisa Marie Oxenham is a licensed home birth midwife in Southern California, and she has over 30 years of supporting mothers and families who want to birth at home, a lot of them in water. And that now is a grand total of over 600 births. That right?
About 645, maybe somewhere in there. Yeah, 400.
It goes up constantly.
That's right. 450 of those are with my husband because he's my
Okay, fantastic. Lisa Marie is a water birth expert, and she also educates practitioners and families on the safety of birthing in water on her Instagram site at Barefoot Midwife. So fantastic. Lisa, we'll get straight into this. So can you tell us when mothers talk to you or families come and talk to you about working with you or having you be their midwife, what are the top three things that really concern them that can happen in labour, complications in labour and birth?
It's a great question, Adam. And often people coming to me are going to be interviewing other midwives. So it's kind of fun to answer from that perspective of them seeking care for themselves. The biggest ones that I get: what happens if the baby has a cord around the neck? Or what if the wife bleeds or their partner bleeds out? They're very concerned about bleeding. Shoulder dystocia, especially if they've had a previous shoulder dystocia in a hospital setting, they're particularly curious about that. I just had a labor and delivery nurse who had a shoulder dystocia who birthed with me and had another shoulder dystocia at home, but we were prepared and it was a very different outcome. They were very pleased.
Okay.
Those are the big ones, I would have to say. And then some peripheral ones are things like, cleaning up and who does what, and that's just
the practical stuff.
Those are the big ones. Yeah, and I have a slideshow that I show prospective clients so they can actually see videos of some of the things that they think they're scared of, and then we talk about how things are handled. And then usually by the time we're done, I feel like that fear is pretty much mitigated, and then they're more open to interviewing other people or hiring.
Okay. Yeah, fantastic. So starting off with the first of those, which is the cord around the neck. Tell us a bit about what that is, how it arises, what might cause or prevent that happening. What is it? What do we know about that?
This is my favorite of the questions, is the cord around the neck.
Okay.
Well, the cord around the neck can be caused from a number of different things. It can be caused from a baby who's not moving a lot, or maybe swirled itself into its cord and then it just kind of stays put. Women with a heart-shaped uterus, sometimes the babies can get lodged onto one part of the heart and then they don't move, so they're just stuck with that cord already there. Or they can get a cord as they're birthing out around the neck. But if a baby has a cord around the neck that's tight in labor, we can tell primarily because of the labor contractions. It's going to tell its own story. So I have this theory. It hasn't been substantiated by science, but it will eventually. Since the placenta is an endocrine organ producing hormones, including stress hormones, and the baby has its own endocrine organ, and the mother has hers, I believe that the three are constantly synergistically singing to each other. So if the cord is too tight, let's say it's a triple wrap and it's around a foot and it's just snug, the contraction, if it's a close pattern, let's say 2 to 3 minutes apart, it's going to create some stress for either the placenta or the baby, in which case the next contraction will be spaced out a bit. I know everyone's experienced this, where the contraction is all over the place. They don't know when labor is going to actually start, or maybe early labor is, you got a 5-minute, 8-minute, 12-minute pattern, then there's no consistent 5 minutes apart, or 4 minutes apart.
It's all individual, isn't it? Yeah.
All individual. And the cord is able to stretch. The baby gets rest in between those waves, so there's good oxygenation happening. The number one complication with a cord around the neck that is tight is an induction labor. This has been proven by so many clients that have come to me where there was an induction, then of course it can lead to fetal distress because that natural built-in rest that comes with an undulating pattern is being overridden by a 2-minute pattern because of a Pitocin drip.
Right.
So that's not a good plan. I wish there was almost a way to check that before they're just in America, we have probably the highest rate of induced birth.
It's in the 30s, it's 30% or so, isn't it?
Insane. But some of those babies aren't going to do well. So the narrative then becomes they had fetal distress because the cord is around the neck, but they're not saying why was it an issue. It's not because the cord is generally. Mostly it's going to be because it was an induction and a constant pattern. And then they get that cesarean and then they feel like, thank God we weren't at home because.
Right.
But I've seen cord around the neck. It's considered normal. I don't even think a thing about it. But I am really passionate about honoring the pattern. I am that one midwife. I know my clients out there who have been frustrated. I don't do any kind of induction because I'm scared to override the intrinsic hormone dance between the triune unit of the placenta baby mother.
Right.
So I won't do membrane sweeps. I've never done a membrane sweep in my entire practice. And I feel like my statistics are excellent. I don't accidentally break waters. I don't introduce infection because I'm not doing that. Hardly ever even check unless there's a problem. So for cord around the neck, you just let the labor unfold naturally, which a home birth setting generally is going to do anyway. Most midwives know that. I don't think I'm the only one who's observed that a cord around the neck baby is going to have a different pattern. Although I wasn't trained in this, it's something I observed just through noticing it and being observant and watchful. So when the baby is being born, let's say there's that cord, there's a couple ways to handle it. If it's a water birth, typically I'm not doing anything. We're just going to let that baby get out. And then the mother and the father have been trained and coached about unlooping the cord and taking their time, babies coming forward. And so I have hundreds of videos of parents actually freeing their own babies from the cord. If it's
so I just want to stop you there because you're distinguishing cord around the neck and cord around the neck tightly.
Correct.
Tight. Those are different, really different things. A cord around the neck itself, if it's not tight, it's not a cause of a huge concern. Is that right?
Right. And I don't know if you want me to ever use my doll, but I have a doll here. Sometimes if the cord is around the neck tight, and let's say the head is out, and that's considered a true emergency where it just cannot progress without removing the placenta. That is a phenomena where the baby is not going to come out without snapping its own cord or removing the placenta to even get out. That's happened.
Right.
And so we're trained where you could clamp the cord, get that baby out, and you'd probably have to do a little resus. But I haven't really had to do that, but I'm willing to do that if it's going to save a baby. But most cords, if you honor that labor pattern, are going to have stretched enough to get that baby out. And even if it's tight when the head's out, you can do a somersault maneuver where you keep the whole body close to the outlet. So the baby ends up coming forward so you can take it off that neck and then free the baby. That's another way to do it. Yeah, I've had to do that before. And I know other midwives have had to do that.
Yeah, okay. So I'm hearing a couple of things then. You talk about honoring the hormonal dance, letting the process that's amazingly developed between mother, baby, placenta, letting that take its course is what you're saying. With regard to is this a tight cord around the neck? Then that's something that you want to be. What is that?
Well, if it's
the right word.
Tight, sometimes if it's super tight, you won't even have progression in labor. So as your friend Nicole Morales once told me, she is an amazing midwife down in San Diego and a breech expert. She once told me I was at a difficult birth. She's like, just always believe the story the baby's telling you. And that has always stayed. Believe the story. If I have a head that will not descend or get into the pelvis after doing all the things, mile circuit, she's had good chiro care, she eats a good diet, That can be a suspended baby where they're literally suspended by way of their cord. And I've seen this before.
Right, right, okay.
We don't force that. You go get help, right? Just go
Right,
get help
right.
so that baby can get born safely. But mostly
Yeah,
that's not going to happen. Mostly those babies can descend into the pelvis. And if it's tight, you're just going to have a longer labor. You're going to have a lot more of that undulating labor pattern and more need to
okay.
sit and not use herbs. Don't herb those pauses. I'm a big fan. I hear this so often where, oh, there was a stall in labor. A stall in labor is still a story that the mother's body is telling you or the baby's telling you. We honor those. Let
Right,
her give her food and hydrate her if she hasn't been drinking enough, and then wait. And that baby will eventually pick up its own pattern and get those babies out. I have honored all the pauses and the labors that I don't use herbs to close the gap because I think they're important.
okay.
We don't know enough
Yeah,
to assume. We assume so much in birth, including home birth. And I am trying to learn to view women as the highest mammal on earth. And if we're going to give all this consideration to gorilla out in the forest, why are we not giving her the consideration that her body has the patterning there for a very specific life-saving reason? So
right.
I'm pretty good about
Wow.
keeping my hands out when it's not necessary.
Yeah, that's
Mind you,
fantastic. Okay.
rules. I hear you, midwives. There's exceptions to every rules. There's certain circumstances where, of course, you have to intervene and do things with herbs. But in labor, I
Yes.
do not.
You're really trying hard not to, is what I'm hearing. Okay, so let's talk about bleeding or hemorrhage. Tell us about that. When that can occur, how can it occur? What are the causes? What would midwives in different settings do, or if that happened?
Let's double back on the bleeding question to the cord thing, because there is a bleeding situation that can occur from a cord with an unaware practitioner. So let's say we do have that tighter cord and she's been pushing, and maybe a midwife or doctor or somebody's getting nervous and they're making her push hard, even, just even kind of not paying attention to her own rhythms, or maybe she's on that drip. That can be a number one cause of hemorrhage, is that as the baby, she's forcing those pushes, she's on her back, and that can cause a partial abruption of that placenta that's in there, because it's that additional time, even with the head out and the uterus coming low. So I'm a fan of, if you do see a cord around the neck, really honor the natural pushing and the pushing desires of the woman. I'll give you an example. Sometimes when there is a tighter cord, I had a baby that had a cord twice around the neck, an arm was pinned down because it was around the waist, and then it was hooked around the foot. And this woman noticed, we both noticed, all of us noticed feedback. Every other contraction was her pushing contraction, and she had a 4-minute pattern. That's how much her body needed that rest. That baby was getting 4 minutes of rest, and then it would have a really big wave that would force her to push. And then 4 minutes later, we call them a placeholder contraction. It's maintaining progress, but not progressing. Well, what do you think happened when that head was out? We had to wait 8 minutes to get the baby out. And the baby did great, though, because it had good perfusion. The cord wasn't being pinched. But had I forced the baby out on the one she wasn't ready, I might have caused a problem. So we just don't know. So bleeding with the cords, yes, honor the pattern. And then bleeding in labor, if she is laboring and not fully dilated and you have bright red bleeding and a lot of it, I'm not talking bleeding from a cervix opening. We're talking something else is happening. We go to the hospital for that. We're not going to take any chances with gushing blood in labor. So that's an automatic transport. And
would you do anything on the spot as well, or is there any kind of drugs that you'd administer then, or would you just?
You can't give Pitocin. You don't want to give Pitocin. You can't give Cytotec. That's going to all cause. You don't know where it's coming from. It's probably coming from a placenta, though. So any kind of drug to make her contract is going to exacerbate it. So no, you go get help. Right. There's not much. You just got to call 911 or just get there. I haven't personally seen this, thank goodness, but I would take it very seriously. And midwives are so skilled at what normal bleeding is in a labor that when you see it kind of streaming out, that's not okay.
Yeah.
Bleeding is
Okay.
common.
That's presumably is that rare? How can we put that in some kind of context?
Yes,
How
it's
rare is that?
quite rare because it's more of a result of a placental thing, a placental
Right.
abruption. The
Yeah.
placenta is starting to come off the uterine wall. You can also have a concealed partial abruption inside the womb where you don't see bleeding, but she's
Yeah.
bleeding. And your only indication
Okay.
is going to be that she is not feeling good. And she's going to tell you something's not right. I feel uncomfortable, or she might have
Okay.
some pain. And it's actually on your NARM exam. So those students who are listening to this, they're going to ask that question about what a concealed hemorrhage, how it's manifested. She's going to look shocky and could go into shock.
Okay.
And so we go and we get help for that. Anytime she's not
Right.
feeling well, you go get help for that when it's that kind of
Yeah.
thing. Very rare. I've
Okay.
never seen that either. That's how rare they are. I haven't seen it. More
Yeah.
common is the bleeding that comes when that placenta is coming.
And
then,
what's sorry.
no, go for it.
And in terms of assessing, you talked about midwives being very skilled at assessing blood loss and being able to kind of gauge how serious it is. How does that change when they're in a birth pool? Because it's a big vessel of water, and therefore, is that harder? What do they do to assess blood loss in a pool?
It'd be harder if you're just kind of winging it. But there were some midwives in the UK who took a birth pool in the box tub and they poured human blood in it at various amounts and took photos. So I have that laminated, and we use that as a guide on terms of what does 500 mLs look like? What does 1,000? What does 1,500 look like? But we have it kind of memorized because we do this so much. I know what a little bit of blood is versus, oh, that's a hemorrhage. Plus, with any Chuck's pads, we're going to be weighing those and converting them into ml. Right. So there's no guesswork. I feel like we're pretty exact with our blood estimate.
Yes. Okay. Yeah. Okay.
Get a copy. Know how much blood, and if you have different tubs, have different photos for those. If you have an Oasis tub, have a different.
Sure, they might have a different color floor or a different color inside that could affect the way it looks.
Right.
So yeah, absolutely.
Our mom, who just did that mountain birth, the one I was telling you about, where we're hiking through the snow to get to her in Lake Arrowhead after that storm. We thought she had hemorrhaged majorly when we first showed up because there was no lights on and you couldn't see through the water. But once we put light on, it's like you could see all the way through. You could read the bottom. It was great. So that was not a hemorrhage.
But yeah.
Midwives, I feel like where we turn on, meaning all my intuition is just flying, is the moment that baby's out, I'm paying attention to her placenta. Typically, a placenta will release after 3 contractions. And that's important to know because if she was in one of these weird patterns, it's going to kind of be random. If she was in, you don't know. So you're waiting those 3 or 6 minutes for the placenta to release.
Yeah.
The body's going to do a contraction that's going to push the placenta off and form a nice big blood clot that helps separate and push it down. So we look for that. But after that, if, for example, if we had been using too many herbs or if it was a Pitocin delivery, she could hemorrhage because the uterus is chronic, it doesn't want to contract. So we are fans of, so for those of you looking for home birth, not interrupting anything after that baby's out. You treat the placenta as preciously as you do that baby. We're not going to be talking. We're not going to be interrupting her thinking. We're going to let her bond to that baby, looking at her baby, talking to her baby and her partner. And then that oxytocin is going to keep that uterus nice and contracted and minimize your bleeding. Also, for people who've had their period in water, we know how our period stops when we're in a big tub of water, when you go swimming. When you're in a large tub of water like that, you actually do bleed less. I know Barbara Harper has some articles on this on her website, waterbirth.org. You can look in the resource section. All of that kind of information is available there for water and assessing bleeding, or take her course. She's got a great course for parents at Birthpedia, a water birth course for parents, just so you know what you expect. It's great. But yes, I'm not afraid of bleeding. I feel like I'm respectful to not overhydrate her. Remember, Adam, you and I were talking about this. Another cause of bleeding is that after the baby's out and the placenta is born, let's say the doula or the midwife has been forcing her to drink water after every contraction because they were trained to do so. Maybe she didn't need a sip after every contraction. Maybe she was perfectly hydrated. I believe the laboring person is designed to go longer periods of time without water. Just like animals, they hydrate and they go and they give birth. And then they eat their placentas and get more fluid from that. But we're interrupting all of this, I think, generally. So I'm a fan of, you're right, letting her do her thing and not offering her water. Let her drink as she wants to. Have it right there. Have it with minerals. Don't do plain water because the cell can't absorb plain water. The cells become permeable with minerals and electrolytes. So everyone knows, like Labor Aid or adding some Himalayan salt or little electrolytes. So we're really passionate about not just overhydrating her.
And overhydrating, what problems can that cause then with the delivery of the placenta?
Especially for primips, if it's a first baby and that head has been pressing on that urethra for all those hours, the urethra will become numb. So, and then let's say she's been over drinking, her bladder's full, her urethra is numb, and the uterus really wants to get into that central place. And now we've got a competition for room, and the placenta is going to be displaced to the mother's right side. And she can't pee. So she's just bleeding. So sometimes we have to cath that. But I have found by telling our birth team, let her drink as she wants to, but don't force it, assuming everything's normal, assuming she's hydrated.
Let her lead, make it available.
I have not seen this kind of bleed I can't even tell you the last time I saw it, since I have a rule. One of our rules is, let her reach for her own, or unless we notice she's thirsty, then of course, but.
Yes, okay.
Honoring her own body.
Yeah, that's a theme of a lot of things that you've talked about. Okay. Are we ready to move on to dystocia?
Yes, that's my other favorite.
So tell us about dystocia. What is dystocia, first of all?
Well, a dystocia is anytime a baby gets stuck somewhere, and they can get stuck in a number of places inside the pelvis and not always on a bone. Sometimes they can get stuck on various ligaments that are inside the pelvis. The head can get wedged funny, or maybe they've got a hand and they're tilted. And so, but the dystocia most people think about is a shoulder dystocia. And that is where, when that baby's head is born and then they're trying to rotate, or maybe they do rotate, baby's out, their shoulder is behind the pubic bone. And you could see that baby is not going to get born just like that. And gravity is not your friend. And pushing is not your friend. It's all about rotation. This baby has to get rotated off of that bone.
Okay.
So, since I'm a water birth expert, it's my passion. Let's talk about this in relationship to a water birth. If I suspect somebody might have a shoulder dystocia because they've had one before, maybe they just kind of make bigger babies. Maybe the shape of her pelvis tends to lean towards that. I'm gonna really ask her to consider birthing in the water 100%. Because I have a lot more time to sort that without it being an emergency. Of the 9 shoulder dystocias that I have had, none of them were an emergency. The babies were stuck, but because we kept the head under the water, we did not initiate the breathing reflex, which gets initiated the moment that the head starts to come into the atmosphere.
Right. So when there's a clock starts, isn't it? Where if you get a dystocia out of the water on a land birth, then you've got a clock, haven't you? And tell us about that time that you've got to manage that issue. What is that?
You do, and usually they're calling out a minute, 2 minutes. Usually you want the baby out by 4 minutes. I know some have taken 6 and they've done fine on a land birth, assuming there's good oxygenation in there. Or maybe there was a lot of room in the yoni and the babies are actually able to breathe. I've heard of that before, where they're stuck, but they're also breathing. That's kind of a interesting situation. And again, like what we talked about, in a water birth setting, your clock is more based on how the baby's doing and what.
Because it's not breathing, it's underwater anyway. So there's no, the breathing reflex hasn't kicked in, which is when you lift the baby out. So you don't have this clock. Yeah, that's interesting.
Yes, and I will not get her out. That's just my rule. That's my comfort. Adam and I when we were talking, remember about you got to do what you're comfortable with. If a person is not trained in water birth and they're super uncomfortable, yes, then do what you are comfortable with. But from my experience with all the babies I've done underwater, I am scared to get them out if there's a baby that's stuck. I'm going to resolve it underwater. I will get my hand in there. I move her to the front of the tub. My whole hand can fit in and I can rotate. And if I can't get the baby out, my husband can. He's really good at shoulder dystocia. His hand can fit in there and he can do that partial rotation. Okay. And so far, we've been able to get the babies out. There is another kind of dystocia where the baby was just girthy, but it wasn't stuck on a bone, but wasn't coming out after the next missed contraction. Sometimes moving tissues can help by pulling the perineum gently over that posterior shoulder. That gives you some leverage to grab onto something, and then you can kind of wiggle them out. Okay. So it just depends on where they're stuck and how they're stuck. But under the water, there's a lot more time.
Yeah. So if you're out of the water and you've got this 4-minute clock, what are the things that midwives will try to do to help unlock a shoulder? We're talking about shoulder dystocia. What are things that people try?
If you can't move, Barbara Harper, her favorite little phrase, and she'll sing this for you anytime you ask her. If you can't move the baby, move the mother. So let's say you've gotten her out of the tub, you're lifting that femur bone, which is going to change the whole shape of the pelvis. And generally they'll have her get on either the running start, we call it the proposal pose, 1 foot flat, 1 knee down, leaning forward so that the midwife can get in and free that posterior shoulder. She'll just, it's all about rotation. We've got to rotate that baby.
Okay.
Yeah, or if it's on a ligament, and there's training, Spinning Babies offers great training for midwives on how to resolve shoulder dystocias, which I've done a number of times. Because they're be stuck in different places. So it's going to be based on her or his training level and how comfortable they are with shoulder dystocia. But that's one of them. They can do Mick Roberts, where they put them on more on their back with the legs back. I don't find that as effective. I find getting in and rotating is just faster and convenient. There's never a reason to have a woman on her back to resolve a shoulder dystocia, in my opinion.
Okay.
Because then you're taking that tailbone and you're pressing it against the bed. So now we've got this baby locked in 2 places, tailbone.
Right.
But when you free one, you have access to that back shoulder, and it's a lot easier. Unless it's just a girthy baby, in which case, try different positions. Just always keep trying something. But also, in terms of shoulder dystocia, I find that there is a way to also, and I know this might not be a popular idea, but I'm going to say it anyway because I've seen it played out and be helpful. If I've had a mom who's had all these 10-pound babies, generally it comes down to a higher glucose diet at the end of her pregnancy. All women are insulin resistant in their pregnancy. It's a beautiful inborn natural thing. So that if there's famine, the food she eats will float sugars longer so that that baby gets fed. Well, in our culture, especially in America, sugar's in everything. So they're getting more sugar than they realize, and their pancreas are going crazy, and their baby's pancreas are going crazy. And they're just putting on all this weight. So I will put moms on a kind of a clean diet at the end of their past 35 weeks can really impact how big those babies are. So I found that, you can have a 9-pound baby that's not fat at all, just long and has a good bone structure. But you can have a baby that's super chubby. So it really depends on.
Right. Yeah, fantastic. Okay. In terms of the other complications that can happen that are less frequently raised by your clients, what else have we got to talk about? Fetal distress, I guess, and that relates to the ones we've already talked about, doesn't it? What would you like to say about that?
It really, really does. And also a lot of times, especially when you're looking at water birth videos, people think the baby's distressed when it's just adapting to the fact that it just got into the atmosphere. This baby, if it's coming out of the water and it's coming into the air, it takes time for that face, the trigeminal nerve to get activated, to open the larynx. The skin's picking up the nitric oxide and carbon dioxide and feeling gravity. All these things influence that first breath. We're just not willing to wait. So in our training, we go over with parents, here's what a normal baby looks like when it's not breathing, but okay. What are we looking for?
Okay.
Blinking eyes. They say eyes are the only organ in the body that are not separate from the brain. It is the brain. So if you have a baby looking around and blinking, that's a good baby. That's a baby getting plenty of oxygen through its placenta. Just wait, and clear your jets. Sit on your hands. Just wait. Let the parents talk to their baby. But if the baby has closed eyes and is flaccid looking, we're not going to ever wait on those. I'm not even a fan of waiting on those underwater. If I see a closed-eyed baby underwater that looks a little floppy, our parents are encouraged to bring that baby right up. We're going to assess fetal heart tones and we're going to get that baby going. We'll try some rubbing first, but then generally PPV, positive pressure ventilation. We'll just jump right on that baby and expand that lungs for them to push that fluid that's still in there into the alveolar so those capillaries can drink it up and increase their blood volume. It gets very technical, but it's so much fun when you understand it. The more you know, the more it helps you to be hands off. I found that the more educated I am, the less I have to do, because I don't want to create the problem by my own fear, by doing something too soon.
Right.
So I have so we show videos of babies in distress, and then we show videos of babies not in distress, and you see me resolving it. You see me giving PPV, and the babies come around pretty quickly. And if they're not responding to that, of course, we're going to do full CPR, with chest compression and all that, which I've only had to do twice ever in my practice.
Twice out of 645. Wow.
Right.
Okay. That's amazing. So the other thing I'm really picking up here is that it seems like keen observational skills in a broadest possible sense is a big part of what you are deploying, and that's helping you decide what's okay and what's not okay, what's honoring the process, what is something we might need to do something about. Is that a good summary?
I would say that is a great summary. And the rest of the complications that we didn't even touch on, like a prolapsed cord. Of course, you're always going to go to the hospital for that. And there's a protocol for getting the head off of the cord and transporting. But those are rare. I've personally never seen that. Thank God. I'm happy about it. We're also really big on knowing where the baby's at. So if I know that head's in the pelvis at the end of pregnancy, and it's more likely going to stay, I don't have to worry as much about the water's releasing, pulling a cord down. And the rest, I think, just they're not as much going to be impacting whether you transport or not. Those are the big ones, the bleeding, distress, and stuff.
Right. And can we say definitively that you kind of protocols around that try to standardize labor and labor progress and things like that, to some extent, that those are not helping? They can cause you to do something that it could just be a pause in labor or whatever else. Is that so? I think what I'm hearing is individualized care.
Yeah,
is really powerful. It's really powerful here.
Exactly. Like Friedman's curve, that was based off of a really small sample of women. And that is the idea of how long first stage of labor should be and how long second stage of labor should be. In the hospital setting, it is a business. They're not set up for labors to take as long as they might need to take, especially for a first-time birther. Our labor delivery client right now, who's now pregnant again, the one that had that dystocia, she's pregnant again. We have a fourth try now. She said when she was on a birth recently that she went out to the nurses station and the doctor and the nurses were just ragging on her client, her patient that was in there, that she was trying to protect their birth. And they're like, oh, she should just go for the cesarean. They're oftentimes having to defend such basic things like privacy. In a home setting, we're not having to do that. They have that. They have their team that they like. It's up to the team then to have that knowledge base to know that the more we do, we literally can create some of the problems that we're trying to prevent.
Right. Yes. Yeah. Wow.
Get educated. Keep learning. Right. We got to keep learning. With midwifery,
absolutely.
The more you learn, the more you realize you don't know. The more intuitive you are, the more you realize how much intuition you need to learn. It's the most humbling work out there. There's not a lot of room for pride. The moment you think, for example, I said to somebody, oh, I'm really good with shoulder dystocia. I had just said this. And then the next birth, I could not get this baby. I was having a hard time. I looked at my husband and I said, I need help. I had never asked him for help when the baby's coming out before. And he came over and I said, you need to get the baby out. And I said it like a fact. And I have this all on a GoPro underwater camera where you see me take his hand, I slide it in along the baby's back, and he had that baby out in 17 seconds. He has very strong fingers.
Wow. Wow.
So
yeah, I think that's it. So humility is a really important part of it, isn't it? Yeah. This has been fantastic. I think that clearly we can't cover everything here. So what we talked about is helping families and mothers understand some of the things that can happen that complications. And I think you just said that people need to make their own, do some of their own homework, do a bit of research, decide what's important to them, what level of what risk they are really wanting to understand better, and then to have conversations with different providers about those concerns. So there's work involved, isn't there, for mothers, and that work is worth it. It's valuable.
Worth it, and there are some sites that people can go to get some education on statistics, which we didn't want to waste too much time here because our time was limited. But mana.org is a great site. Evidence-based is a great site for learning about how the science is. And the CDC even has some things if you want to compare against hospital outcomes. And then my page, homebirthfacts.com, there's links to everything on seeking out a home birth and statistics between hospital-based midwives versus home birth midwives. What do the numbers look like? So yeah, by the way, the numbers are favorable. Home birth has amazing, amazing statistics, especially if you consider relative risk, meaning you remove those high-risk people, remove breech births, twins from the equation, and it's astounding how safe home birth is, or birth in general. Right. Most midwives would tell you that if we transport, it's not an emergency. It's been for pain relief with primips. And even that I reduced, right? I had my first transport in 2 years this year. So for a first time mom. So
rare. That's rare.
Almost nothing. Yeah.
Yeah. Wow. That's amazing. And so you've given some places people can go and find out more. That's fantastic. I think we're going to wrap it up here. Lisa Marie, thank you so much. This has been really interesting. And I think that you're not the first speaker to talk about the hormonal dance. I think that's something that and honoring the process and honoring the mother and baby placenta dynamic. I think that's such a big takeaway for mothers thinking about their births. And you did touch on avoiding fear and preventing fear, and it's a delicate one, isn't it? Because you're talking about complications. You need to do that to reduce fear, but also it can make people dwell on those things, right? So keeping that in perspective is a challenge.
And preparing the families, if the families know, oh, the midwife is familiar with these complications, this is what she would do to handle them. When I've had dystocias, for example, the families didn't even know. They had no idea that it was one she knew, but usually I'm just resolving it, and I'm trying to keep my nervous system in the safe, calm state, and keep because I don't want her to then hemorrhage because she's got all this adrenaline. But it's worked. It's worked well. Yeah. Thanks.
Fantastic. Well, thank you so much for talking to us today. Really appreciate that. And I'm going to stop recording now.
Perfect.